It's working now. Good afternoon, everyone. Welcome to the Cross-Border Surveillance Plenary Panel. You've made it to the last session of CUGH 2024. Welcome. For all the attendees that are way in the back, please come join us closer. I promise you, none of us will bite, none of us will quiz you. We want you closer. And to get us started, please take a look at this question that I have. Note that I have 3 different ways to participate, and I want to test this right now because we're going to have this sort of pulse throughout our presentation. So please participate. Now, while I see your responses, good morning, good afternoon, and welcome to the Cross-Border Surveillance Plenary Panel. My name is Solange Madriz, and I have the pleasure to be your moderator today. I work at the Institute for Global Health Sciences, and I've been there for the past 13 years, but I started my career as a global health practitioner at CUGH. You may not know this, but CUGH was actually part of UCSF. And I worked back then with my colleague Hannah Park, who was the executive director, and my very good friend here, Robert Mansfield, when global health at UCSF was 3 people, Dr. Hailey DeBass, Robert Mansfield, and his executive assistant. And through the years, then they decided that CUGH should belong to the world, and so they separated from UCSF, and I helped with all the efforts to make it an independent, no-profit organization. I see here that a lot of Californians are dominating the room, so welcome all you Californians, but I'm actually more interested in seeing from this list who is the person who is traveling the farthest. I see here Peru, maybe. Oh, India is here in the room. We have Virginia Republic. What is this Virginia Republic? I see a flag here. Bay Area, maybe. Oh, to participate in this type of exercise, you need only one word to make it work. But welcome, everybody. OK, so we're going to have these exercises, and I see that many of you are able to participate, so it is working. Now, I would like to switch back to my presentation. I would like to share with you the objectives of our panel today. And the first one is to demonstrate the relationship with cross-border surveillance and pandemic preparedness. That is going to be one of the messages that we want to leave you with. The second one is to describe common issues across 3 different regions of the world around this topic. And the third is, of course, we're here at CUGH, so we would like to share what is the role that academia and universities can have for this topic. What do we have prepared for you today? We're going to have introductions. We're going to have a colleague to have a common vocabulary for cross-border surveillance. Then we're going to have 3 region-specific presentations. And we're going to end with a panel discussion, then your questions, and then we're going to summarize everything. Throughout all this presentation, we're going to have lots of polls. So we'd love for you to take your cell phones. This is the type of plenary that we would love to have your cell phones. So hopefully, if I see you like this, it's because you're answering our questions, or you're trying to figure out how to make it work. With that, I would like to start the introductions. And the first panelist is my colleague, Farah Massoud. Farah is our program manager at the Center for Pandemic Preparedness and Response at the University of California, San Francisco. Farah plays a crucial role in coordinating and enhancing surveillance capacities in the region. She has managed various surveillance projects aimed at improving health outcomes in Egypt, Morocco, Jordan, and Oman. She's also working on leveraging innovative approaches to strengthen cross-border surveillance and disease response in the MENA region. MENA stands for Middle East, Northern Africa. We also have Dr. Francis Kakuza, And Dr. Francis Kakusa is the Global Health Security Department at the Infectious Diseases Institute. He's the lead of this department at Makerere University. Dr. Kakusa has a PhD in molecular epidemiology, and he's currently working with UCSF, the University of California, San Francisco, to roll out implementation science trainings in 12 national institutes of public health in Africa, in collaboration with MasterCard Foundation and Africa CDC on the partnership with Saving Lives and Livelihoods program. Next panelist is Dr. Ietza Bojorquez. Dr. Bojorquez holds a PhD in epidemiology, and she is a Master's of Science in Public Health. Her main research interest is on the social determinants of health in the areas of migrant health, mental health, health policies, and health-related practices. Since 2010, she has been a professor researcher at the Department of Population Sciences at the El Colegio de la Frontera Norte in Mexico. It's also known as El COLEF. Last, but certainly not least, I would like to introduce our very first speaker. It's my colleague, Laura Bubak. Laura Bubak is a technical advisor in global health security at the University of California, San Francisco's Center for Pandemic Preparedness and Response. Laura has worked for over 15 years and has extensive experience working in public health research, training, and surveillance across sub-Saharan Africa, Southeast Asia, and the Middle East with academic, UN, and non-governmental organizations. She has recently led a mixed methods research study landscaping cross-border public health surveillance in the MENA region, and believes cross-border surveillance depends on a multidisciplinary approach involving diverse partners and approaches. With this, please help me in welcoming my colleague, Laura Bubak.
All right. Thank you, Solange. It's an honor to be here this afternoon alongside these panelists from Jordan, Uganda, and Mexico. Okay, so we have the opportunity today to hear from these speakers from 3 continents who'll be delving into the details of cross-border public health surveillance. But before they begin, I wanted to introduce some key concepts on this topic. I know we have some of you in the room who are also experts on this topic, but that also some of you have never worked in this area before. So my goal here today is to bring us all on the same page, understanding the definitions, key concepts before we hear from these panelists. So the theme of CUGH this year is Global Health Without Borders. In the context of pandemic preparedness, we've all seen how COVID-19 is a disease that has no borders, and also how quickly disease can transform from a local outbreak into an international pandemic. So here we see a comparison of global travel routes from 1933 up top to 2020 on the bottom, showing an increased connectivity, but also an increased vulnerability to quick spread of pathogens across geographical borders. This is not only due to international travel and transportation, but also the many shifting trends that we have been discussing over the past few days here at CUGH. This includes animal and plant trade, seasonal migration, conflict, climate change, urbanization, among many other factors. In our current global health context, a health threat anywhere is a health threat everywhere. Detecting transmission across borders has never been more critical, and that is where cross-border public health surveillance comes into play. The most important components of any public health surveillance are the collection, analysis, and dissemination of results for action. And this occurs at all levels of the health system. In cross-border public health surveillance, we're specifically talking about public health surveillance data that is contributed by more than one neighboring or regional country. This may be operationalized in different ways, but the objective remains the same: to mitigate the spread of public health threats across borders, as well as fostering partnership and collaboration amongst countries. So here I'd like to demonstrate two different mechanisms for cross-border surveillance. In some cases, this may be one country sharing information directly with another country in bilateral information exchange. In other cases, this may be neighboring countries sharing data with an international agency who compiles, analyzes, and shares the data when there is a potential threat. Such institutions may be multilateral, non-governmental, or academic organizations. Regardless of how countries share their health information across borders, they are bound to share information such as epidemiological, laboratory, clinical, and other relevant health information of international concern under the International Health Regulations, or the IHR. The IHR are a set of legally binding international rules with the goal of preventing, controlling, and responding to the spread of diseases across borders. The IHR were created by WHO and member states, and they're currently under a lengthy review process in our post-COVID era. And they're largely implemented at points of entry, or POE, which is any border area with a passage for international entry. This could be at air, sea, or land. And cross-border surveillance is also implemented within border health programs that you'll hear about from our panelists that focus on mobile populations and the communities that they visit before, during, and after travel. The next definition I'm going to speak about is mobile populations, and it came to our attention in our research that there is no universally or internationally accepted definition of migrant. Yet, there are an estimated 272 million migrants, representing 3.5% of the world's population. So as we're striving to share as well as compare data across countries, this is very challenging when our definitions and our indicators do not align. And in many cases, this leads to underreporting or missing reporting of potential threats, especially amongst those of the world's most vulnerable populations. So here we have a working definition of mobile populations that has been developed by the US CDC Division of Global Migration Health. And it describes people who are on the move, whether for short or long distances or durations. And we're striving to include all types of mobile populations, from travelers to forced migrants to internally displaced, nomadic, and others. So given this variety of types of mobile populations, this also requires a wide variety of data sources and data collection strategies necessary to reach and meet the health needs for prevention, response, and health surveillance. Cross-border surveillance requires a myriad of different data collection strategies to ensure we include all types of mobile populations that travel across borders, and that we can collect, analyze, and share data on all of those mobile populations. Oops. Okay, I think we're... All right, so we all have a role in cross-border public health surveillance. Our ministries of health cannot strengthen cross-border surveillance alone, as you will hear from our colleagues. It's really a cross-cutting field that requires to include not only the health sector, but also other ministries of agriculture, environment, animal health, But also within the health sector, we have many disciplines that we will hear our colleagues talk about, as they're all experts in different types of health sector approaches. So finally, our speakers will share all of their experiences and challenges, but they all represent different academic and research institutions. So I invite you all to reflect upon this question as you listen to the panelists. What roles can university or academic partners play in strengthening cross-border public health surveillance? So we will come back to this question after you hear from all of the panelists. So please keep this in mind as we get into the discussion from our panelists. Thank you.
All right, it is time for our second poll of the day. So please, everybody, take your cell phones, computers, and I would like to ask you now, if you're listening closely to this, to Laura, who just presented, I would like to ask you to please answer this question. Is this true or false? There is an internationally standardized definition of migrant. Is this true or this is false? Okay, I have 4 people joining. I can see, something I should say. I don't know, I actually put this to be anonymous. So I don't know who's answering what. So feel free to please answer as what you think it is. I'm not looking at names. There's no way for me to track. And I work at a university. So I could lose my job if I say something like this and it's not true. Because everybody could say, oh, but she's lying. I have 16 of you in the room participating. And then now I want to see the reason why you're not seeing responses is because I don't want biased response. All right, and now I'd like to turn it. I know the right answer to this. Laura, are you happy or are you unhappy with this?
It looks like the majority of participants were listening, and in fact, there is no internationally, I think that was supposed to say internationally, so there was no internationally standardized definition of migrant, so that statement is false. So if you missed that part, that may have been why you got the wrong answer.
96% responded correctly.
96%, okay. Great work.
Now you know that we're now testing your listening skills. So next, I would like to turn over to my colleague Farah Musod to give the next presentation on cross-border surveillance in the MENA region. Please back to the presentation.
Good afternoon, everyone. Thank you for being here on the last session of CUGH, and I'm very happy to be here. So today I'll be presenting about the the importance of cross-border disease surveillance in pandemic prevention for the Middle East and North Africa region. So all of the information that I will be sharing today is part of the work that UCSF and the Centers for Disease Control and Prevention, the CDC, specifically the MENA office and the Global Migration Health Department have worked together the past year. And I've mentioned here some of the collaborators, and Laura, who just presented, is also one of the collaborators. So just a quick outline for my presentation. I'll give you just a brief background, talk a little bit about the research methodology, and then I'll talk about the context, challenges, and the innovations for the 3 key themes that have emerged out of our work. So these themes are the information systems for disease surveillance, and also the information sharing policies and partnerships, as well as mass gatherings. And I'll end with some conclusions and recommendations and our work's next steps. So in terms of the significance of cross-border surveillance for the MENA region, we know that in the MENA region there is a lot of animal and human migration for several reasons, like trade, travel, and also migration for the purposes because of political instability as well as economic instability. So at the moment, there are 2.4 million refugees in MENA, almost 13 million internally displaced people, and 24 million migrants. So this is a huge number, and of course, this causes an increased challenge for disease surveillance, and that's why we need cross-border public health surveillance systems that are needed. And we're working on this because in the MENA region, no landscape analysis or systematic reviews in this area have been done before. So our research objective is mainly to look at how cross-border public health information is collected, analyzed, and shared within the MENA region. And we want to look at the differences between the countries and across the different mobile populations. And we also looked at what would promote and what would inhibit cross-border disease surveillance. In terms of the research methodology, we conducted a systematic literature review using the PRISMA approach, and we looked into almost 101 sources from 24 MENA countries that were published between 2012 and 2022, and we looked at those with certain key terms that link to mobile populations and disease surveillance, and they were all published in English. And then we conducted qualitative key informant interviews, and we did 21 interviews with participants from 7 countries, and we also had 7 participants from regional stakeholders. So out of this work, we had 6 key themes that emerged, but for the sake of this presentation, I'll be talking about 3. So the first one is information systems for disease surveillance. So we looked at, again, 24 countries according to the World Bank classification. And these countries were very different in terms of their income and their contexts. So, of course, they had varying surveillance systems as well. However, all of the countries that we were talking with or worked with in the interviews and through the literature reviews, most of them reported having an electronic information system. But this varies in coverage geographically. For example, it differs from one point of entry to another, like airports, seaports, and ground crossings, and of course across the mobile populations. Also, few countries integrate the data from their point of entries that they have into their national surveillance systems. And a lot of them reported that health facilities are the main source of information for them, and this is the case for Sudan and Yemen, for example, because for refugees in specific, because refugees are integrated within the national population, and all of the information is received about them through health facilities. And also, this is the case for Oman and, for example, the UAE for travelers in specific, because they have a strong traveler surveillance system. So for the challenges, that data completeness and timeliness is always an issue, and we also have the inconsistencies in the definitions used across the MENA, and the data quality in many traditional data sources might be also an issue, and reaching communities like nomads, for example, in deserts of Oman or Saudi Arabia, or of course reaching the very big refugee population in many countries in the Middle East. The second key theme is information sharing policies and partnerships. So again, because the MENA region is very different in terms of the income and has a lot of variability, it is very important to establish partnerships and policies to ensure that we have timely and accurate information sharing and also resource sharing. So in most of the MENA countries that we worked with, they reported that the international health regulations, the IHR, is the main framework that they follow through, and they communicate and share data through usually the IHR focal point. However, the challenges still persist, of course. And in some cases, like the Gulf countries, the Gulf Countries Corporation, countries follow the GCC frameworks for public health emergency preparedness and response. In terms of the challenges, there's the lack of national level mechanisms for information sharing. For example, in Libya, they reported that the country doesn't have the proper mechanisms to share information from points of entries to rapid response teams. Also, we have the reluctance of countries to share the data that they have, and incompleteness of the data shared between the countries, and of course, the lack of coordination and communication between the donors, the partners, and other stakeholders. So an interesting case study that we came across through our interviews with the Gulf about partnerships is the Gulf CDC, or the Gulf Center for Disease Control. And the Gulf the Gulf CDC is a regional network for information sharing. And in 2021, the Supreme Council of the GCC approved the establishment of the GCDC in 2021. And it serves as a regional hub where they share information, where also all activities related to health coordinations and capacity building and evidence generation happen at the GCDC. And it's mainly for the 6 member states, which are Saudi Arabia, UAE, Oman, Qatar, Kuwait, and Bahrain. So during our interviews, they mentioned that this is a very successful collaboration because specifically they mentioned during the COVID-19, it was really helpful because they were able to share information easily, and there was this kind of trust between these countries. So all of these countries followed the health policies and regulations and guidelines that were developed by the GCDC, like the lockdowns, travel bans, and other specific recommendations. So even after COVID-19, the GCDC is still maintaining this network for the member states, and they meet on a weekly basis. They have a team from each member state, like the IHR focal point, someone from lab, and surveillance. They meet on a weekly basis to discuss any health threats that they may have. Then we have the third key theme, which is about mass gatherings. So the Middle East, or the MENA region, hosts some of the biggest mass gatherings like Hajj and Umrah, which happen in Saudi Arabia on an annual basis. And then there is the Al-Arba'in, which happens in Iraq. And in this mass gathering, for example, there is almost 20 million travelers from all around the world that they go for almost 2 weeks there. So we know how mass gatherings can put a lot of strain on the health systems. Especially because of the threats that they have, because of the spread of diseases with epidemic potential. So these countries, of course, they face a lot of challenges in terms of mass gatherings, and the ones that were mentioned are regarding the forged test results at the points of entry, like with the COVID-19 situation, and lack of traveler real-time data and disintegrated data from multiple systems. However, they have some innovations that they have and have been implemented earlier, which is the use of mobile data to identify high-risk individuals. And in 2016, during Hajj, Saudi Arabia piloted the use of electronic wrist bracelets also to track travelers. And of course, screening and monitoring of attendees before and after they go for the mass gathering. So really quickly, some recommendations about the integration and innovation. So we need to have We need to integrate disease-specific surveillance systems because in many countries, for example, in Sudan, because we have many donors, a lot of the systems are vertical, so it's very important to integrate those. Maybe have an influenza surveillance data from each country into a MENA region-wide system. And we need to also have innovative data collection methods for refugees and nomads so that we can reach them in a better way. And then for expanding partnerships, it's important to increase the number of MOUs between the agreements and the data sharing agreements between these countries. Of course, foster the One Health approach that includes community engagement and multi-stakeholder engagement at the national and international levels, and partnerships across international organizations, academia, and the private sector, especially in countries that are facing political instability. And then for mass gatherings, we need to employ innovations in blockchain to ensure that we have valid tests, vaccine passports, and electronic bracelets. But we also need to make sure that these innovations are not invading the personal privacy of these travelers. And we need to strengthen the provision and delivery of drugs, vaccines for attendees to mass gatherings. So in conclusion, cross-border disease surveillance is very important for monitoring the health of mobile populations, specifically in the MENA region because of the large number of migrants, travelers, IDPs. And we all know that the MENA region is going through a lot in terms of the political instability. And enhanced collaborative partnerships, information sharing mechanisms, and innovative technologies are very important to address the health of mobile populations. In terms of our next steps for the project, I want to mention that UCSF, in collaboration with the CDC, will be working with academic institutions in MENA to develop and pilot an academic course for graduate or undergraduate students to be piloted in the year of 2024-2025. And the objective of the course is to train or educate the next generation of public health professionals on the key components of border health and cross-border surveillance, both theoretically and practically. So you can scan the QR code here to register for a webinar that we will be having on March 20th to discuss this opportunity of funding. It's open for institutions or academic institutions in the MENA region. So if you know anyone who might be interested, please share this invitation with them. And thank you very much for listening. Thank you.
All right, it's time for another knowledge check. Everybody pull up your cell phones, go to www.polev.com/crossborder to answer the next question, which is, activating. In your opinion, what is a major challenge in cross-border surveillance in the MENA region? Option A, high influx of refugees, migrants, or travelers. B, lack of legal frameworks. C, political instability. Or D, lack of surveillance technology. Again, to join this poll, please go to polev.com/crossborder. Or you can also send a text to 22333 and cross-border, and then you select A, B, C, or D. Okay, I see here 21 of you, 23 of you, 24. One person log out. What happened? Okay. And in the meantime, I'll show you the responses. I now have 28 of you, but I know that there are more than 28 here. Wow. A lot of you are saying letter A, and I'll turn over to our regional expert, Farah. What do you think about A?
To know people's
microphone
opinions.
not working. Hold on
Hello?
1 second. It may be, oh, it is working now.
Thank you, Solange. Actually, it might look like a difficult question, but there's no right or wrong. But in my opinion, I'm very glad that people have picked the first option because it is a very big problem in the MENA region, in addition to the political instability, of course. So thank you all for participating.
This was a trick question, and you all got it right. All right, so back to now our presentation. I'd like to introduce you again to Dr. Francis Kakusa for the next presentation on cross-border surveillance in the East Africa region.
Okay, so good afternoon, all you colleagues who have made it to this last engagement. Thank you for dedicating time to join this discussion on cross-border health surveillance. My name is Francis Kakoza. I'm from the Infectious Diseases Institute at Makerere University. At the institute, I serve as the head of the Global Health Security Department. And this is a department whose goal is to strengthen health systems in Africa to be able to prevent, detect, and respond to public health emergencies. So I have an opportunity today to share with you a few slides, about two, on the work we have done in cross-border health surveillance, and especially the lessons that we can take away from here. So when we're having a discussion with the entire group that is going to present today, the discussion was, how do we ensure that there is context in what we're going to share, and that way the different members can appreciate. So for those who don't appreciate well, Uganda is in the eastern part of Africa. And in that eastern part of Africa, it is to the left bordered by DRC Congo, to the north it's South Sudan, and then to the east it's Kenya, to the south is Tanzania. But when you look broadly in the community, it has Burundi, Rwanda, and Somalia. So if you follow the geopolitics in that region, one, you will appreciate that Uganda is the leading host country of refugees in Africa, with up to a total of 1.5 million refugees that are hosted in Uganda, coming from DRC Congo, South Sudan, Somalia. So there is a civil war going on in the southern part of South Sudan. There is a bit of insurgency in the eastern part of DRC Congo, and the same with Somalia. So that puts Uganda at a risk of a lot of cross-border associated health risks because of the influx of refugees. But also, by the nature of where the country is situated, in the Albertine region, in the Congo Basin, which makes it, I would say, the right culture media to have pathogens grow and propagate in this region. So with that, it takes me to share with you an explicit map of Uganda, which has the designated points of entry. And these have been designated as points of entry for trade, for immigrants, for travel. And at those points, on top of customs clearance, there's also a lot of border health screening, temperature, and also a lot of evaluation of clinical symptoms and signs in relation to filoviruses. But also you will note that on top of what is the designated points of entry, there are other porous entries into the country, which are over 40. And these are the ones where a lot of some smugglers, if I may say, for trade, and others who are coming in as refugees or immigrants used to come into the country for various reasons. So that puts the country in a bit of a peculiar situation, Peculiar in a sense that there's a lot of influx of, in terms of travel, in terms of population, and that way there is need to strengthen its cross-border health surveillance. Now, the focus here is mainly about what we have done, and mainly the work with points of entry has been mainly around advancements in surveillance, in preparedness, and in response. And also, this has been done to ensure that there is strengthening of coordination between the public health emergency operation centers. And this means that the emergency operation centers in Uganda, coordinating with the neighboring countries in DRC Congo, South Sudan, Tanzania, Rwanda, and Kenya. So I'll summarize the experiences in just 3 blocks here. And we can pick it up from there to have a more detailed discussion. So the first one is the need of decentralization of international health regulation assessments to subnational level. So my colleagues, as they were opening up the session, they went deep into the international health regulations. If you follow these very keenly, their assessments are at national level, what is commonly known as the joint external evaluations. Now, joint external evaluations give, they give a score at country level, which is good enough, but when you look at it deeper, it is a bit biased. Because if you say you have an accredited lab that can do XYZ testing, but you don't have that capacity at a border district, then with these pathogens, it's a bit of a challenge, because it will mean that you have to collect the sample at border X and transport it up to the central lab. And that means you're exposing, the entire chain. One of the challenges we had in the last Ebola outbreak was in the emergency medical services, where one of the nurses in the ambulances got infected because of transportation from one place to another. So the first need here to strengthen cross-border health surveillance is the decentralization of international health regulations. On top of conducting national assessments for JEE, countries should now move it to subnational level. And that way, for example, if we are to use like the PEPFAR structure, and you look at health regions, I'll take an example of my country, then you have to know how many health regions do you have in that country, and what is the subnational capacities for preparedness and response away from the national level. I think that is very important, because that way you can be able to know that if you have a risk or you have an outbreak in that region, what capacity do you have to contain it, to detect it, and to manage it at source. So that is the first key recommendation from the work and the experiences. The second part is the establishment of regional emergency operation centers, the public health operation centers. And again, from our experience in Uganda during COVID, a lot of the capacity was at the national level. Everything was, central. The coordination, the IMT, the incident management teams, the dispatch, the logistics, the budgeting, the entire coordination, which again is a challenge. Take an example. If you are to pick up a suspected patient with VHF up at the border between South Sudan and Uganda, how long does it take to ensure that the central EOC can be able to coordinate a response, dispatch an incident management team, get a team that can do sample collection, transfer the sample to the central lab? So these have been the main reasons we get a lot of spillover of the outbreaks. So for cross-border health surveillance, there is need to target to regional emergency operation centers. That way you can know that if there is a port of entry center X that screens all immigrants coming in, all refugees, all traders, then all these results don't have to go to the national source, but they have to be relayed to the regional center that can be able to get the data. If it meets the threshold to activate a team, then the team can be deployed in real time and you manage the issue at source. Now, finally, is after you have managed to do the joint external evaluation, you know the capacity at subnational level. You have institutionalized regional emergency operation centers and linked them to cross-border health surveillance. What is needed is the electronic integrated disease surveillance and reporting system, which is still a gap on the African continent. And that way, we are not able to pick up the alerts. Sometimes when you go for data quality assessments, you can pick up some outbreaks in some of the records that were not picked up. And it's only when you're doing an assessment that you realize, oh, there was a threshold here. How come it was not picked up? And here again, I'll go back to the huge investment we have had from PEPFAR. And this is the community health structures. How do we ensure that our community health structures, the VHTs, can be empowered with this work? So here, there is a lot of need to roll out this training. Ensure the training of EIDSR is rolled out to the communities. And on top of that, you even give them the capacity to be able to report. This is a very simple to use tool. It's an Android-based simple messaging system that just ensures that if there is any suspicious case in the community, a community healthcare worker anywhere in the village can be able to go into the phone, type out this case, send it on 6767, and this is picked up at the regional emergency operation centers that I've mentioned about. Now here, that means anyone in the community, their level of education, it doesn't really matter. It is something that is very easy to use. And this is now what we are rolling out in Uganda to ensure that communities are empowered, the VHTs have the knowledge of EIDSR, and that way you can be able to link whatever happens in cross-border health surveillance, whatever they pick up as they screen the different populations that are entering into the country. It can be linked to the EOC and for the EOC to act. All right, thank you so much for listening to me, and that's the experience from Uganda and East Africa. Thank you.
We're going to make sure that they were listening, Dr. Kakusa. So right now it's time again for our next poll. And this one, it's about something that Dr. Kakusa just mentioned. 1 second. All right. The instructions are here. I'm going to activate and present to you. According to this presentation, centralization of international regulations is necessary to strengthen cross-border surveillance in the Eastern African region. Is this true or is this false? I see 15, 16 of you already here. To join this poll, please go use on your cell phone or your computer. Go to pollev.com/crossborder and answer the question. You can also send a text message, but better if you're international, don't do that because I don't want you to get a bill just to answer this question. So just use your cell phone, your navigator, and go to pollev.com/crossborder and answer this. So 32 of the audience members are here, but I don't want to show the answers yet because I don't want response bias. Dr. Kakusa, you ready? Okay. 37 of you. Can one more person respond out there to get us to 40? 3 more people. Okay, so the responses are true. 16% said that this is correct. that we need centralization of the international health regulations is necessary, but the majority said false, which is the right answer. Is that correct, Dr. Kakusa? And why, can you remind us one more time, why is this necessary? Decentralization, so this is false. This is a false statement. But why is this false, Dr. Kakusa?
Maybe I'll try to amplify my voice. Because the mic is off. So it's false. As mentioned, we need to decentralize the evaluations at subnational level. That way we are able to know how regions are performing in regards to preparedness and response. If you get a national level score, it will give you a result that gives you comfort that you have laboratory capacity. However, if you pick up an outbreak in a corner district, say neighboring DRC Congo and South Sudan, but you don't have the lab capacity there, that means that you have to transport the sample, which is having likely Ebola, from that border to the testing lab, hence exposing. So we need to decentralize the joint external evaluations to subnational level. Yeah, thank you.
Thank you. Thank you for, we wanted to emphasize that because this is one of our key messages that we wanted to highlight. So that's why my emphasis on this question and bringing Dr. Kakusa back one more time. Okay, so we've traveled all the way from MENA region, then Eastern Africa, and now we're going to come a little bit closer to where we all are. And I'm going to go back to my presentation and introduce one more time to Dr. Yetza Bojorquez, who's going to talk about the U.S.-Mexico, the United States and Mexico border, as well as the Mexico and Guatemala border. Welcome, Dr. Bojorquez.
Okay. So I want to start in a personal note, telling you about 15 years ago when I came to live in Tijuana at the Mexico-U.S. border. And back then, I wasn't really interested in borders, per se. I was interested in migration. But after living there for a few years, I have found that the border is a very unique region. And it's of course, it's very different from what happens in the center of the country. And also that borders at the international level, I mean, in the border areas of many countries and many regions share common traits that are very interesting and also very important for the purposes of epidemiological surveillance. I think one of the main things to remember about borders is that these are places of a very rich cultural and social exchange, and economical, and let's say social for short. And this exchange is part of what makes communities in these borders be binational, sometimes trinational or many national communities that have these unique characteristics. So focusing on the region I work in, which is Mexico, Central America, Mexico has two major border areas, one between Mexico and Guatemala, and the other one between Mexico and the U.S. And they are very different, as you can see in the pictures. On the one hand, you have the Mexico-Guatemala border, which is more or less an open border. There are official sites where you can cross, but people mostly crosses almost everywhere where it is possible, and they have been doing that for thousands of years probably, but at least hundreds of years, even before Mexico and Guatemala existed. And they are used to do that, and there are families that live on both sides of the border, members of the family on one side and the other, people going back and forth for work, for commerce, for education, for health services. And it is relatively easy to go across the border. On the other hand, you have the Mexico-U.S. border, which is much more difficult to cross. It has this huge wall in many parts of it, and it's heavily policed. And when we talk about epidemiological surveillance, it is very interesting because if you Google surveillance Mexico-U.S. border, what you get is pictures of the wall. It's not epidemiological surveillance, it's migration surveillance. So we, working in public health in different capacities, need to be aware of this situation and how epidemiological surveillance is intermingled with these other social activities of migration surveillance and other things that happen in the border region. So another interesting characteristic of the borders is that many different types of, we call them migration flows, move across the borders, and that's just an image of some of the migration flows we address in this survey, but it's just for the purposes of illustrating how, especially in the Mexico-U.S. border region, but also in the Mexico-Guatemala region, we have on the one hand people migrating across the border, which is a very difficult thing to define, as we saw in the first presentation, but also people moving back and forth without aiming to change their address, without aiming to come to reside in a different country, just moving for shorter periods. For example, it's very common for people to move for work during the week and then go back during the weekend to their place of origin or the place where they actually live. And we also have people going for work in the morning, coming back in the evening, etc. And they do that in different geographical points and in different conditions. Then when we need to create an epidemiological surveillance system or many systems for these regions, it is really very important to try to cover all these types of movements. And when we talk about epidemiological control, as in the COVID-19 pandemic, one of the probably the main lessons I think we learned is that you can't close a border, really. You can close a land border at least, maybe an airport, you can close an airport, but you can't close a land border, especially in very porous borders, as we have between Mexico and Guatemala, but even in the Mexico-U.S. border. Because during the pandemic, I assume some of you are familiar with the regulations that were in place. So the border was open only for people who had a residency or a type of residency in the U.S. There's many people, for example, living in Tijuana who were born or are citizens or are residents of the U.S. and live in Tijuana because it's cheaper, and they go to work in the U.S. during the day or during the week. So those sorts of people, those commuters, were moving across the border even when it was supposedly closed. So then, from an epidemiological point of view, we will still open, or there was still the possibility of transmission at a time when the main public health, quote unquote, action was to close the border. So one of the issues I want to highlight about the borders in general is that they can't be closed, these land borders, especially, again, probably airports, probably water borders or other types of borders. Land borders can't be closed, and you have to account for that in your epidemiological surveillance or your actions to protect public health in these areas. So some examples of what is done currently in the binational surveillance at the Mexico-U.S. border, and I'm not mentioning examples in the Guatemala-Mexico border because there are very few and they are very local. These are the first 4 ones are long-established collaborations. One of them is even from the past century. It started in 1999, and they have been created, and probably since many of you are from California, you know about these initiatives more than I do. They have been established in order to account for this special dynamic of the border, and they are focused, of course, in communicable disease, infectious diseases, but there are also other initiatives for non-communicable diseases. And they include aspects of capacity building, aspects of surveillance itself, and aspects of response, public health response for also the following up of cases. For example, the CUGH TB is a good example of trying to follow up TB cases as they move from one side to the other of the Mexico-U.S. border, and trying to provide continuity of care, which is very important for the TB treatment. There are other initiatives for HIV, for example. So for these types of diseases that require long-term or mid-term therapy, there are these different initiatives. And the Binational Technical Working Group is very interesting because that's a working group of decision makers, actually, at the state especially, but also at the county or municipality or jurisdiction level, depending on the country. And the BTWUG was especially active during the pandemic. They had weekly or even more often meetings, and they exchanged information about how the pandemic was evolving in their communities in both sides of the border. And this was done in a very, well, they had technology, they had systems in place, and they have different ways of doing that and accessing information online, etc. But what I want to highlight is the low technology effort that took for people to sit down in a Zoom room for a while, for a few hours every week, and discuss and plan and respond to the needs of each community on each side of the border. And that type of collaboration is not something that can come up overnight. So the presence of all these initiatives in the border region for such a long time was that made the region able to respond very quickly and very efficiently to the COVID-19 pandemic, even quicker and more efficiently than the federal or national levels of the response, because they had these established collaborations. The fifth bullet is the CDC Mexico Country Office, which also oversees many of the other ones. But I want to tell you a little bit about a relatively new initiative that I have been involved with. That is the research initiative that, among its many aims, has the aim of creating new ways of surveilling the movement of cases of epidemiological diseases of epidemiological interest. And one of the things we have been doing in that is using surveys of mobile populations across the borders, across the Mexico-Guatemala border, and see if that can itself become eventually a system of epidemiological surveillance. It has a lot of implications, a lot of difficulties, but I think it's a very interesting thing to follow up. And another initiative is the Border Health Commission, which is not just for epidemiological surveillance, but it's a way of collaborating at the federal level between the two countries, but in which also the state and local levels are involved. And here I want to follow up on what Francis was telling about the need for the decentralization. And I think one of the very interesting things that happens in the borders is that people do what is needed. They don't wait till they have permission from the central level or the federal level to do things. And that's, to a point, that is a very good thing, because that's the localization of efforts, of public health efforts, and local actors are much better placed to respond to some different problems at some times. So this interplay between the federal binational federal relationship, state level binational relationship, local level or jurisdictional level binational relationship, I think it's one of the things that one needs to watch if one wants to create a good system of epidemiological surveillance, a public health response at border areas. Because these are areas that require that local view in order to be able to understand the many issues that are going on there. So my three key messages are, first of all, cross-border surveillance is a form of binational collaboration, and it needs to be supported and enhanced because it is a much more effective way of dealing with public health threats than border closures. And at least in the Mexico-U.S. border, it is already present, it is very strong, and what it needs is continuity and keeping improving on it. For this collaboration, one essential element is trust, and trust is built over a long time, a long period, and over many experiences that people have shared over the years. So even the continuity of actors, of people working, if it is the same people that is working in these systems across time, that facilitates these types of collaboration because trust is built in this context. So, well, there's a need for support for that. And finally, local and state level collaboration, binational local and state level collaboration, that it's also sometimes called paradiplomatic or paradiplomacy, that should be recognized by the governments of both countries, in this case the US and Mexico, and how these local and state level collaborations can come up with very interesting initiatives that are not even thought of at the federal level because, well, they are not here, they don't see what people on the local level see. So those are my key takeaways, and thank you.
No more polls, but before we get to the discussion portion, I do want to take a few minutes to reflect a little bit on what Dr. Bojorquez was talking about. She talked about the differences between the US-Mexico border and the difference between the Mexico and Guatemala borders. From the word cloud that we created at the beginning, I see that many of you are coming from different countries that I would say most of them have borders. So right now what I would like to do is actually, I think I'm sending mixed messages to the team back there because I do want to throw another poll, but it's not a poll, a question poll, but it's a word cloud. I want to show you from all this, you said, the people here, these are the participants of this one. Californians, the size of the word increases by the number of people that are typing that. So most of the people that responded this are from California, but I see here, Brazil is here, well, one participant from Brazil, Indonesia, Nigeria, Tennessee, France, Canada, Uganda, Vermont. All of this, I don't think that there's no, Peru, India, all of this are countries or borders. So now my next question to you is, when you think about borders, in one word, and I would like to beg you to one word, otherwise we're not going to make a nice word cloud. We're going to make a messy cloud. I would like to ask you to please tell me, what do you think when you think about borders? We answered this already. This one, not yet. No yet. Hold on 1 second of the, can we stop sharing 1 second? Oh, we're not sharing yet. Okay, perfect. But think about what's something that you would like to write in our word cloud, and to participate, go to polev.com/crossborder. And I'd like to throw another poll here. 1 second. Okay, so if I can please have my poll back. Yeah. And what word comes to mind when you think about borders? One word. Again, to participate, please go to polev.com/crossborder. You can also send a text message if you have a US carrier you need to send cross-border and your message to 2333 and send your word. I see over 20 of you are responding, and I'd like to present this. Some of the words that I see here are, well, this is changing. This is going to make me a little bit dizzy. But I see here opportunity, interface. Collaboration is the most written word. Porous, interface, corruption, culture, political, line, infectious, fake, culture, immigration, restricted, humanity, conflict, limitations, scaring, restrictive, humanity, arbitrary, division, restrictive, collaboration/segregation, fear, Trump, tools, social. What do you make of this, Dr. Bojorquez?
I like it very much, really. Yeah, and I like that the first word is collaboration. I like it so much, and I think that's a reflection of the sort of persons that are in this room, that we are all in the same page, that we need collaboration in this area. So thank you very much.
Yeah, I think that this is a global health audience, so the biggest word is, of course, collaboration. All right, so thank you, everybody. And now I would also like to highlight that we're gonna turn over the discussion for all the panelists. I'm going to ask questions to the panelists, but I would also like to open a question that is, what questions would you like to answer the panelists? And please write that question. I'm going to stop sharing my screen now, but I would like to open that poll. It's a question, it's not a poll. And then I'll also like to ask my panelists to log in here, and if there's a question that you really want to answer, tell me, Solange, I want to answer this question to this person instead of my question. We don't have a lot of time, so please, everybody, all my panelists, go to paulev.com/crossborder, because I'm going to open my question about what questions do you have for the panelists. So what you're going to see there, I'm not going to show them right now, but my panelists, if you see the question and you like to answer that instead of the question that I have, please do so. I'm more interested in having the questions from the audience.
It's Paul what?
Paul F. Paul, yeah.
Okay, so it's what questions do you have for our panel, and it's activated, and so you can answer. I'll show you 1 second. Yeah, there it is. Thank you. The instructions to ask questions is go to paulev.com/crossborder, and nobody has answered anything, but actually we can leave this open in case some people can see the questions. Okay, so now my first question for this discussion will go to Farah. Farah, talking about, we've heard a lot about regional collaboration, and that's actually the largest word in the word cloud. Can you tell us a little bit about the barriers to regional collaboration in MENA region for pandemic preparedness, and what initiatives have proven successful to overcoming these obstacles?
Thank you, Solange. That's a very good question, and I mentioned briefly the Gulf CDC during my presentation, and I just wanted to mention about this is that the Gulf CDC, there's plenty of work that happened before. So the Gulf Cooperation Council for the countries that I mentioned earlier was established in 1981 because of their shared objectives, their geographic proximity, and because they have similar political systems. So they have been working together since then, and I guess that's a very important thing to consider, that it's been a lot of time since they have built this trust. So when the Supreme Council approved this, the initiation of the Gulf CDC, it was proven successful, and this was based on our interviews from several members from the GCC, from the surveillance or the Ministry of Health in general. So I just wanted to highlight the part where trust being built is very important. And also I want to mention another example, which is maybe less of a success, but it's still a very big step forward, which is the Khartoum Declaration. And in 2018, Sudan invited all neighboring countries to discuss information sharing and response to cross-border events. And these included Egypt, South Sudan, Ethiopia, Chad, Libya, and I think only Eritrea and West African Republic did not attend. However, they signed the Khartoum Declaration. So they discussed data sharing agreements. They revived the MOUs that they have. And they also created common or mutual rapid response teams that can respond to cross-border events. And they discussed resources like lab. So, but the thing about that is when we discussed this with colleagues from ministries of health in Sudan, unfortunately, they weren't very confident about the success of this initiative or of this declaration. And that's because Sudan has been going through a lot of political instability, as you may know. So they always say that it's a very important step forward, but again, I think they will be focusing on that after things stabilize. So in my opinion, there are a lot of challenges, and these, of course, include the political stability, the political relations between the countries, and lack of trust between the countries. And this was interesting in Sudan because with the relationship with the Gulf, for example, because the Gulf imports livestock from Sudan. So when I was doing the interview, they said they don't usually share a lot of information with them. For example, if they have a Rift Valley fever case, if they mention that or share that with the Gulf countries, they would stop the importation, and that would affect their economy really badly. So even if Sudan provides them with certain lab tests or lab results, negative tests, to show that the samples are okay, there is still that mistrust both ways, and they do not trust the capacities of Sudan, let's say. And this, I think, happens in several of the countries in the MENA region. So thank you.
I hear the word mistrust. Okay, thank you so much. And Dr. Kakusa, I think that the audience has questions for you. I'm going to read. Oh, can we go back to the polls, please? Oh, I call it polls, but it's not called polls, it's Q&A.
Sure.
Oh, okay. I like this question. I assume that it was for Dr. Kakusa about how do you train. Okay, so Dr. Kakusa, the audience is asking, somebody from the audience is asking, in Uganda, how do you train village health teams on reporting? What to report and how?
Sure. So thanks. How we train them, we use the electronic integrated disease surveillance and reporting system. And if you appreciate this system, it has different facets. There is the pattern indicator-based surveillance, which is mainly for the hospitals, and it's linked to DHIS2, the routine data collected in hospitals. And also there is event-based surveillance, and this mainly picks up cases, any peculiar cases in the communities. So what we do is that when we are supporting the Ministry of Health to roll out the EIDSR, there is a training that is focused for the health facilities, and that is mainly the healthcare workers. But also there is a training focused for the community, which is mainly the event-based. And under the event-based, it gives you like a questionnaire that you need to, to be able to complete. For example, are you seeing this symptom for the first time? Is it happening a lot in the village and things like that? And all that you have to do is to SMS to a specific number, and this information is picked up at the Emergency Operations Center. So in summary, it's mainly using the EIDSR platform and focusing mainly on event-based surveillance, focusing on community healthcare workers. Yeah, thank you.
Thank you, Dr. Kakusa. And this question is for Dr. Bojorquez, if you feel comfortable answering this. How migration policies impact in the U.S.-Mexico border surveillance?
Thank you. Thank you for that question. Yeah, Well, the first thing is that migration policies create a group of people that needs to hide from the authorities in order to survive and continue with their migration projects. So by creating that group of people, these policies are creating a hidden population, and hidden populations are very difficult to follow up and to conduct surveillance with. So that's one major issue, I think, and I think that's one of the challenges with these types of population, how to reach people who doesn't want to be seen, how to see people who doesn't want to be seen. And the other thing is the migration politics are creating in borders all over the world places where people get stranded, so they are living in very difficult conditions, bad hygiene, etc. So that creates the potential for outbreaks of all sorts of diseases that also requires epidemiological surveillance.
Thank you. Perhaps this question if anybody's comfortable speaking from your own region, what data systems are used to collect and share health information for borders if you can speak on your own regions? Would you like to, perhaps Dr. Kakusa?
Sure. So again, these data collection tools are usually customized according to specific incidents of the different outbreaks that you have in the country. And they are customized from the IHR. In the IHR, they are the appendices which pick up on what information you collect from passengers or any travelers that are coming into the country. Specifically in Uganda, this health tool is more inclined to filoviruses or viral hemorrhagic fevers, and goes into mainly screening what early signs and symptoms are associated with these VHFs, and that is the main information. I think the challenge we have is that it's still a paper-based system. It's not electronic at the moment, so it's mainly completed, in a paper-based manner and scrutinized by the port health team to see if there are any incidences that have to be followed up. Thanks.
Do you want to answer for the MENA region?
Yeah, I would say there is not a universally accepted or used health information system, which brings the challenge of information sharing. The WHO Regional Office for the Eastern Mediterranean does coordinate a lot of the information sharing along with Gulf CDC, but the electronic data systems really vary by each country. And so there is not any unified platform that allows, for easy facilitation of this. But I also wanted to say, I saw a question up there about if we're familiar with MECIDS within MENA, and yes, we have come across that. And if you are here, we would love to meet you, so please find us after this consortium amongst, Israel, Palestine, and Jordan, and particularly with building lab capacity and sharing of lab data across these countries. So we would love to connect with anyone from MECIDS if you are here.
There's a question about
I think this is a good question for you, Farah. In MENA, especially during peak time,
for Hajj, yeah.
Yeah. How do such travel restrictions perceived by travelers?
Yeah, I don't know if you know, but Saudi Arabia hosts this on an annual basis for Hajj. And unfortunately, in the past years, there was a stampede where a lot of people died and they weren't able to identify those people. So a lot of progress has been done from the side of the ministry, and they have a specific mass gathering unit now at the Ministry of Health in collaboration with the WHO that regulates all aspects of the health for Hajj and Umrah. And they have a program, and they're trying to make it as easy as possible for travelers from abroad, where there is an application, and they give them all the needed health education. They tell them about the vaccine requirements and the recommendations, and they also have to fill a WHO document, health document that has been agreed upon and released 2 or 3 months before. And of course, they do all the point of entry screenings, all going into one system. So the fact that it's all on an application and is going into one system, I think that is making Hajj easier for travelers. And they've been using some of the innovations like the electronic wrist bracelet so that they can track by GPS and they can track all their health information. So I think they're still working on more innovations, but so far they're doing good. But again, we need to consider the privacy of these people, and of course not to overwhelm them with a lot of innovative technologies. Thank you.
Thank you, Farah. And now we're getting to the end of our discussion, and I would like to end with this question for Dr. Bojorquez. If you had a magic wand, what are the 2 things you would like to see to improve the outcomes in your work region? And your region is the U.S.-Mexico border.
Okay, if I have a really magic wand, I will disappear the borders. No, but a relatively less magical one. I would like to see these binational collaborations more and more institutionalized, more and more recognized within the programs of the administrations of both countries, the federal administrations of both countries, so that they are sustainable in the long term. I think that will be one. And the other one, and I have said this multiple times, will be for the federal and national level to recognize the importance of the local initiatives in developing surveillance, epidemiological surveillance.
Thank you. And I would like to invite Laura to summarize and to tell us what are the key messages that you heard from all these wonderful speakers. If you can have our slides back, please.
Okay, so the question I asked at the beginning, thinking about the role university and academic partners can play in strengthening cross-border public health surveillance. So hearing all of those questions and engagement from you all, I know you were thinking about this. I wish we had more time, as this field is really new and emerging. And so what we see a huge role for all of us is really to build the evidence on what is working, for piloting new strategies like we saw, Francis talking about documenting and evaluating the innovations, all of the innovations we heard about in MENA, at all of the different levels of the health system. Sharing the lessons across countries and regions like we did here. We hope we continue to see this topic on the CUGH floor as well as other conferences, as well as promoting workforce development and training. This comes all the way at the local level with community health workers up to the level of national surveillance officers, ministries of health, even the university level. So these are just some of the ideas that we thought all of you can continue to work on strengthening cross-border surveillance in global health. So with that, thank you to all of our panelists. Thank you to our moderator, Solange. Thank you to you all for participating in the polls. And we're all available for questions and discussion after as well. Thank you.
There's actually one more poll, which is your evaluation of this panel. So I would like to activate. You don't need to show my messy desktop anymore. Just you can show that. Yes, thank you. And now, but I would like to activate the survey of this panel. And I would like to encourage the panelists to please take a look at the questions that the audience wrote. Dr. Kakusa, your name was there specifically. So and there's somebody who wrote her name from Ethiopia who would like to hear from you. So thank you to everybody. I really appreciate this discussion. I appreciated your participation. And as my colleague Laura said, we would like CUGH organizers to bring this topic, which is a new topic, back to this conference. Thank you, everybody, and congratulations for graduating from the CUGH 2024 conference. Bye, everyone.